Hello and welcome. The complete blood count is one of the most frequently ordered tests in all of medicine, providing a vital window into a patient's health. Today, we're diving deep into the world of hematology. We'll cover the essentials you need for your exams, from normal blood values and coagulation to the interpretation of blood films, and a detailed look at hematological malignancies and their groundbreaking treatments. Let's start with the basics, normal values. For an adult male, a normal hemoglobin is around 13.5 to 17.5 g or DL, and for a female, it's 11.5 to 15.5 g or DL. A normal white blood cell count ranges from 4 to 11 by 10 L, and a normal platelet count is between 150 and 400 by 10 shell. Deviations from these values often point toward underlying systemic diseases. A common finding is anemia of chronic disorders, or ACD. This develops in patients with chronic inflammatory conditions, infections, or malignancies. The key lab features are a mild, normocytic, normochromic anemia with a low serum iron and low total iron binding capacity, but importantly, a normal or high serum ferritin. Other systemic diseases also leave their mark on the blood. Chronic renal failure causes anemia primarily due to a lack of erythropoietin in production. Chronic liver disease can lead to a macrocytic anemia and, because the liver synthesizes most clotting factors, a significant bleeding tendency. Malignancy can cause anemia in many ways, but if it infiltrates the bone marrow, you may see a characteristic leukoerythroblastic picture on the blood film, which means immature red and white cells are being pushed out into the periphery. Next, let's talk about stopping bleeding, the process of hemostasis. This involves three main stages: primary hemostasis, which is the formation of a platelet plug; secondary hemostasis, the activation of the coagulation cascade to form a stable fibrin clot; and finally, fibrinolysis, to break the clot down once the vessel has healed. The coagulation cascade is a series of enzymatic activations, classically divided into the intrinsic and extrinsic pathways, which meet at a common pathway to ultimately generate a stable fibrin clot. We assess this cascade with two key screening tests. The prothrombin time PT measures the extrinsic pathway and is used to monitor warfare in therapy. The activated partial thromboplastin time aPTT measures the intrinsic pathway and is used to monitor heparin. To truly understand what's happening with the cells, we need to look at them directly on a peripheral blood film. The universal standard for staining these films is the Romanowsky stain, such as a Leishman or Giemsa stain. The principle is simple. It's a mixture of an acidic dye, ASN, and a basic dye, Azure B. Acidic structures in the cell, like the DNA in the nucleus, are basophilic and stain blue or purple. Basic structures, like the hemoglobin in red cells, are eosinophilic and stain pink or red. In addition to routine stains, we use specialized cytochemical stains to differentiate between cell types, especially in leukemia. Myeloperoxidase MPO and Sudan black BSBB are crucial because they stain granules within myeloid cells, helping us distinguish between acute myeloid and acute lymphoid leukemias. Prussian Blue is used to stain iron in bone marrow aspirates, allowing us to identify the characteristic ringed sideroblasts seen in myelodysplastic syndromes. Now, let's move to hematological malignancies and their treatment. Chemotherapy uses drugs that are destructive to rapidly dividing malignant cells. Because they target fast-growing cells, they inevitably affect normal tissues that also divide quickly. This leads to the most common toxicities: myelosuppression, low blood counts, mucositis and diarrhea, damage to the G-tract, and alopecia, hair loss. Let's review some key drug classes. Alkylating agents, like cyclophosphamide, work by cross-linking DNA strands. A classic, high-yield side effect of cyclophosphamide is hemorrhagic cystitis, or bleeding from the bladder, which is caused by its toxic metabolite, acrolein. Antimetabolites like cytarabine and methotrexate interfere with DNA synthesis. High-dose cytarabine is a cornerstone of acute myeloid leukemia treatment and is notorious for causing cerebellar toxicity and chemical conjunctivitis. High-dose methotrexate requires careful monitoring and leucovorin rescue to protect normal cells, as it can cause severe renal and hepatic toxicity. Anthracyclines, like daunorubicin, inhibit the enzyme topoisomerase II. Their most feared long-term side effect is a cumulative, dose-dependent cardiotoxicity that can lead to heart failure. Vinca alkaloids, like vincristine, work by preventing microtubule formation, which stops cells in mitosis. The dose-limiting toxicity for vincristine is peripheral neuropathy. In recent years, treatment has been revolutionized by targeted therapies, which interfere with specific molecules involved in cancer growth. The poster child for this approach is imatinib. It is a tyrosine kinase inhibitor designed to block the ATP binding site of the BCR-ABL fusion protein, the specific molecular driver of chronic myeloid leukemia, or CML. Another key targeted therapy is rituximab, a monoclonal antibody that targets the CD2O protein found on B cells, making it highly effective in treating B-cell lymphomas and leukemias. Let's briefly spotlight the key diseases. Chronic Myeloid Leukemia (CML) is a myeloproliferative neoplasm defined by the presence of the Philadelphia chromosome. This is a translocation between chromosomes 9 and 22 that creates the BCR-ABL fusion gene. Patients typically present in a chronic phase with a very high white blood cell count, showing a full spectrum of granulocyte maturation, from blasts to mature neutrophils. Chronic Lymphocytic Leukemia (CLY), on the other hand, is a cancer of mature B lymphocytes. It's often diagnosed incidentally in older adults who have a persistent, high lymphocyte count. The classic finding on a blood film is the presence of fragile, broken lymphocytes known as smudge cells. A serious complication of CLL is when it transforms into an aggressive large B-cell lymphoma, a process called Richter's transformation. And there you have it, a high-yield review of essential hematology. We've covered normal blood parameters, the coagulation cascade, the art of interpreting a blood film, and the core principles of chemotherapy for hematologic malignancies. Integrating this knowledge is key to both passing your exams and providing excellent patient care. Thank you for watching. Study smart, and we'll see you next time.